We look at the hidden gems of psychopharmacology, starting with Pramipexole. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue.
In 2003, I opened a psychotherapy practice in Western North Carolina. I didn't set out to focus on treatment-resistant depression, but the problem came to my door in patient after patient, as it does for many in our field. In most towns, people get their first-line psychiatric treatment, the SSRI, from primary care, and only come to us if that doesn't work. And for a lot of people, it doesn't work. Somewhere between 30 and 60% of patients do not reach full recovery after 2 or more antidepressant trials. That 30 to 60% range comes from different interpretations of the STAR*D trial. The fact that it is such a wide range tells us something important. Defining meaningful recovery is not an exact science. These patients with treatment-resistant depression are really a varied bunch. They include older adults with vascular disease, patients with bipolar features, inflammation, insulin resistance, dysthymic temperament, childhood trauma, and chronic stress. And I learned pretty quickly in the 2000s that the algorithms we had to treat them, raise the antidepressant, switch the class, add bupropion, buspirone, or a stimulant, were not meeting their needs. This wasn't like antibiotic resistance, where they just need IV vancomycin or some other magic bullet. These depressions I was seeing were complex and needed an approach from many angles: lifestyle, nutrition, sleep, medication, psychotherapy, and sometimes neuromodulation.
The STAR*D trial has a step-by-step algorithm for treatment-resistant depression that reflects how psychiatry was practiced in the 1990s. The problem is, most of the steps in that algorithm have failed in large randomized controlled trials. John Rush, who led the STAR*D trial, has since turned away from that approach. He proposed a new title to replace treatment-resistant depression, Difficult to Treat Depression. And that is the title Dr. Aiken took for his new book, which we're going to read an excerpt from today. The book covers psychotherapy, lifestyle, neuromodulation, and CAM approaches like light therapy, omega-3 and probiotics and medications, lithium, antipsychotics, thyroid, as well as novel agents that have new support from randomized controlled trials, amantadine, minocycline, celecoxib, D-cycloserine, and Pramipexole.
In the past 2 decades, I've tried just about everything with a randomized trial in treatment-resistant depression, and Pramipexole has been one of the most useful. But as I set out to write this book on difficult-to-treat depression, I hesitated. My own experience might be biased here. Pramipexole works in both unipolar and bipolar depression, and I'm a bipolar specialist. Pramipexole works better in depressed patients with high inflammation, and my practice borders on the region of the U.S. with the highest rates of inflammatory conditions like obesity, metabolic syndrome, and vascular disease, near the Appalachian Mountains. So I had reason to doubt that my own experience with this dopamine agonist would translate to the rest of the country. But as I finished the book, a new trial came out from England that forced me to bump Pramipexole up from 3rd line to 2nd line for treatment-resistant depression.
The study was unlike any other we had seen in treatment-resistant depression. 70% of the trials that supposedly look at treatment resistance enroll patients after just 1 antidepressant failure, not the 2 failures the definition requires. This study got it right, with an average of 3.5 antidepressant failures, and 21% had failed augmentation trials as well. It was also large, enrolling 150 patients. Dr. Aiken found that many popular strategies for treatment resistance worked in small or uncontrolled trials, but then failed to make a difference in large placebo-controlled trials. Strategies like augmenting with mirtazapine, bupropion, buspirone, or stimulants. Finally, this study tested the drug against placebo for a full year, and it held up for the entire year with a large effect size. Very few augmentation strategies have that long-term data. Lithium does, but most antipsychotics failed to make any difference in depression when they were tested against placebo for more than 3 months. So let's get to it. Difficult to Treat Depression is available in paperback and as an audiobook, and we're going to play the Pramipexole chapter from that audio right after the CME quiz. Earn CME through the link in the show notes. Pramipexole is selective for which dopamine receptor? A. D1, B. D2, C. D3, D. D4. Chapter 21, Pramipexole.
Pramipexole is a dopamine agonist that is highly selective for the D3 receptor. This receptor is involved in the antidepressant actions of aripiprazole, brexpiprazole, and cariprazine. Outside of those, D3 is rarely a target of psychopharmacology. In the pathophysiology of depression, however, D3 is a central player. D3 receptors are densely packed in the nucleus accumbens, the seat of motivation and reward. When these circuits are overactive, people seek out pleasure at any expense. When they are underactive, people have no motivation to do anything. They are tired, slowed down, and anhedonic. They give up easily if they start at all, caught between the guilt of avoiding action and the drudgery of taking it on. This sounds very distressing, but distress is not the best choice of words for this apathetic state. Patients with anhedonia are less responsive to pleasure and pain. This numbing extends even to their experience of depression. They may tell you that everything is okay as their mood is worsening. They may run out of medication and neglect a call for a refill, instead waiting for their next appointment to raise the issue. Why does dopamine decline? Old age, inflammation, stimulant and cocaine misuse, and chronic stress are common causes. The key word there is chronic stress. Acute stress tends to raise dopamine, inspiring action and paradoxically improving depression. Under chronic stress, after about 6 months, dopamine declines and depression sets in. Evidence in depression. This dopamine theory motivated clinical trials of pramipexole in treating depression. After its release as a treatment for Parkinson's disease in 1997, researchers noticed improvements in mood as well as movement, something not seen with the dopamine precursor levodopa. In animal models, pramipexole reversed the passive depressive state that sets in after chronic stress. In 2 small controlled studies, it treated bipolar depression better than a placebo, with a large effect size of 0.77 to 1.1. The manufacturer tested it as monotherapy in a phase 2 trial of major depression, where it surpassed placebo and equaled fluoxetine. Psychiatrists encouraged the drug's manufacturer to press on with phase 3 trials, but the impending generic release made it hard to justify the cost. Pramipexole was shelved as a treatment for depression. It did earn FDA approval in restless leg syndrome and improved mood in a large placebo-controlled trial of patients with restless leg syndrome and depressive symptoms. Putting aside the trials in Parkinson's disease and restless leg syndrome, pramipexole's benefits in depression are supported by 7 randomized controlled trials, 2 of which involved bipolar depression. Pramipexole works as monotherapy and augmentation. Its benefits are large even in treatment-resistant cases where it has an effect size of 0.9. Most importantly, those benefits are durable, with a placebo-controlled trial showing sustained effects for up to a year. Pramipexole is one of only a few pharmacologic options with evidence in patients with high degrees of treatment resistance, even if that evidence is only observational. It brought remission after failure of aripiprazole, ECT, and over 6 antidepressant trials. Unlike most therapies, its efficacy does not diminish as the degree of treatment resistance goes up, although patients with high degrees of resistance may require a higher dose, like 2.5 milligrams a day instead of 1.5 milligrams a day. When to consider pramipexole. Pramipexole is appropriate for patients with treatment-resistant depression and bipolar depression. Candidates who may particularly benefit include those with marked anhedonia, amotivation, and psychomotor slowing, high levels of treatment resistance, including multiple failed medication trials or ECT, inflammatory markers or inflammatory medical conditions, comorbid restless leg syndrome, soft signs of bipolarity, and bipolar depression where it should be used with a mood stabilizer. Pramipexole has no known benefit for addiction or misuse. Patients who are prone to psychosis or OCD may experience worsening of those symptoms on it and are less ideal candidates. Anecdotally, I have had the most success with pramipexole among the second and third line options in this book. Mechanism of action. Pramipexole is a selective agonist at the dopamine receptor that regulates hedonic drive, D3, in the nucleus accumbens. There are 5 dopamine receptors, and pramipexole's affinity for D3 is 7-fold higher than the others, including D2, the receptor involved in psychosis. Pramipexole belongs to a newer class of dopamine agonists, the non-ergo alkaloids. This class represents a safety advantage over the ergo alkaloids, bromocriptine and cabergoline, which cause valvular heart disease at high rates, 20 to 25%. The newer dopamine agonists appear to be free of that risk, which is caused by activation of 5-HT2B serotonergic receptors in the heart. The other non-ergo alkaloids, ropinirole and rotigotine patch, lack placebo-controlled trials in depression, but did improve mood in observational studies and trials in Parkinson's disease. Compared to pramipexole, rotigotine is slightly more selective for D3, and ropinirole is less selective.
We'll pick up next week with the nitty-gritty on how to use pramipexole. Difficult to Treat Depression is available in paperback or audio. Here's what Andrew Penn, professor at UC San Francisco, had to say. Aiken proves himself to be the premier translator of clinical psychiatry research into pragmatic and clear clinical advice for psychiatric providers. I intend on making sure all of my PMHNP students leave training with a copy, knowing it will be well used in their practice for years to come.